Medica hospitals. So he's going to talk on evolution of sepsis definition. Sepsis, evolution of sepsis from the beginning. Definition also has been changing time to time. So he's going to elaborate on sepsis definition, how it changed, and what is the management for each time of changing the definition. Thank you, sir, for selecting this topic. And I request Dr. Mohan Maharaj sir to start the presentation.
Thank you, sir. Thank you all for joining for the talk. This is my actually workshop talk in Eurasia tomorrow. I thought I'll take this opportunity to, because yesterday it can be used and many people can give me a contribution and suggestion and deletions, whatever I can do. So the talk is evolution of sepsis definition. So what is actually the definition? So definition is depends on, like, for example, if you want to define a marriage, it's a legal relationship of two human beings. Or if you just want to define a crow, so it is not a flying insect, it is a bird. So like that, you have a different, sandstone. The compression of sand is a sandstone. So the definition gives you the source, what is it and what is it is not. Both the things it will give you. And if it comes to the medical terminology, medical cases, it gives you the different varieties of what domains of usefulness of the definition comes. And it's a research you're useful, and the treatment of clinical care is useful, and it can be useful for surveillance, it can be used for quality improvement and audit. So the definition should give you all these things, and it requires actually 4 steps when you want to define any disease. So it requires epistemological underpinning of the name of that, what you're going to do, and it should give all relevant terms used in the definition should be relevant to that, and which actually should be intended to the purpose for any proposal set of the criteria. And also it has to give approach to inform whether it's going to be how you're going to treat clinically, and it regards to the intended purpose has to come out of. That's called definition. So when it comes to definition, it's been there since many, many decades. We know what actually sepsis is. We will tell you how it has been started since the beginning. But actually, when you go to the sepsis, this one, it actually go into the 6 domains. No, it's a reliability and content validity and construct validity and criteria validity and measurement burden and timelines. These are all important when you want to define a disease or a syndrome or anything you want to give, because that should give you the treatment, that should tell you, guide you where it is important to be given that. So that is what actually definition of anything. So the evolution of definition started from, actually we know it is started first in Egypt. This is actually called Ebers Papyrus. So this is actually medical book, you can say. It's available in a museum in German. It is almost a length of more than 110 pages, and which is written in that how to treat, because particularly at the time they were not doing any internal, only external things, and like snake bites, all these bites, what has been there. So that time itself, that was 1550 BC itself, before Christ, they have in the Egypt they have termed called ukedu. So this is actually meaning that there is something which we don't know, organism or whatever it is available in the intestine, which is actually enters into the body, that will cause suppuration and fever. So you understand how previously we know about this, how early we know about this, what actually is the meaning of sepsis at the time of a great scientist. So that was this is the medical text of Egyptian people. It is simply written as a, actually what is the definition in the simple words is, it is an explanation of meaning of the word. So that is actually the definition. So at that time, the sepsis is known as this. So it was in 1550 BC. The later is one of the great man, is Homer. So he has written in his epics saying that there's in poems what he read. That time itself is written. The word sepsis has come from the sepo. Sepo is actually means I rot. So at that time he has been written saying that the rotten, that means there's a issue. What is happening is there is a almost tissue which is actually dying and it's becoming dangerous to the body. So that he has been said from the Greek word. So that time in the medical context has been written in 8th century. That was a development what we have seen in the understanding of sepsis. Later, we all know the Hippocrates as 400 to 300 to 400 BC. The first definition of sepsis has come. That is where the definition has come to sepsis. What actually it has come into? There are two things. One is a good and is a bad. So good is a sepsis and bad is a sepsis. So that means there is a decay of living things. That is, living things die and decay. That is a definition of sepsis in K. It is a process of death and decay associated with illness, putrefaction, and a foul smell. So that they call it as a sepsis. And whereas it's a good thing, whatever is happening, decay that results in well-being, like for example, making the fermentation of grapes to wine or digestion of food, that has been called pepsis. I don't know whether pepsin has come from this or not. So this is how the first definition of sepsis has come in 460 BC. And if you see later on, which is coming to the Chapani. So the in 25 before Christ and 50 you see common era, Aulus Cornelius Celsus, who is actually developed. See, look at the intelligence and the of that authors, what they could able to do exactly greatly. It is they could able to understand the cardinal manifestations of inflammation. That is a rubor, choler, dollar, and tumor. So that was in 25 BCE, but afterwards, around almost another 50, 60 years after, the man called Galen of Pergamon, so who's actually has termed fifth inflammation cardinal manifestation, which is called functio lassa. So these are the five things which actually come into that evaluation of that time, saying that that's called rubor, collar, dollar, and tumor, which is nothing but including the functio lassa, nothing but in today's our clinical context, we can say rubor is nothing but vasodilatation, collar is nothing but heat, which is a fever, and the dollar is nothing but a capillary leak, which causes pain. And you can say that altered mentation is a dollar and the tumor is a pain. And the fifth sign, what I told, functional loss is nothing but organ dysfunction. So this is what the knowledge and the author what he has given us in 2000, I mean long back, before 2000 years. But what happened was at that time, there was a spontaneous theory, because some unknown things are used to happen. That's why the people are becoming sick. So there's something called spontaneous general theory was there, and which the spontaneous general theory, which is bad things used to come and kill the patients. If you see that time, the population of the world is somewhere around 100 crores, and many people used to die because of that. So in 1676, actually, Mr. Anthony van Leeuwenhoek has found out the which is not visible through the eyes, the microbes, which is seen the invent of the microscope. He found out and he became a father of microbiology. That is where the entire the department of microbiology is existed, started. Okay, and with that, even though he has done somewhere in 1676, it takes almost more than 100 years. Once the Louis Pasteur has found out the patient condition of usefulness of this, and Simivilis and Angry made importance of patients microbiology definition of this and how the people are dying, how the people are saving. And at the same time, the Robert Koch is understanding about medical microbiology, which is somewhere in 1876. So it took almost 100 years when all these people has come and found out, people world started believing after development of pasteurization, vaccination, immunization, and importance of hand washing, and understanding the how this pathology, the invent of the antibiotics, which has come with this, the germ theory has come into the understanding and acceptance of the world. So these are the four great people who have been contributed to the importance and how the from spontaneous theory to the reality practical germ theory has been coming to the work. If you see that in almost 1900 to 2000, that is 18th century to the 19th century, the death crude death rate was very high, and including in America and throughout the world, where after development of antibiotics like penicillin and vaccines like Salk and Sabin vaccine, and also the Vaccination Assistance Act, and all these things, so they able to control by all this methodology by chlorination of the water, and the population has been really increased from 100 crores to 700 crores. So, because the death rate has come down to the minimum from the infectious diseases, not other diseases. So, this is how the development has come and prevention has come, antibiotics come, and bacteriology and microbiology has come with the development of understanding and identification of fungus and bacteria. So, this is the story goes, and the definition is nothing but the act of defining or of making something definite, distinct, or clear. So, this is what we are supposed to do for our today's sepsis definition of it has come. So, if you see that with that, after previous knowing about all these things, now came to the picture of who was a Polish man, Richard Pfeiffer, who was actually identified whatever is coming from the bacteria which they're able to identify, it has gone into the human beings and made a host response reaction which is coming from the body. So that is identified as endotoxin by him, which is actually he not understood whether it's a gram negative bacteria, gram positive, but at the time he could able to understand something which is actually, even if it is not alive, that membrane is going to cause the damage to the patient, and that's he has understood as a endotoxin. So then again, after almost, you can say in 40, 50 years, there's a surgeon who's called Cooley. So he's actually used this, he called it as Dr. Cooley's remedy of mixed toxins make one disease cost of the. So this is actually whatever is the, like, erysipelas germs, which actually he managed to give it to almost, you can see that here, 430 cases, and probably 150 sure cures. That means so tumor lysis has happened. So when the tumor lysis happened because of this, and he was being people supported, promoted, again had a lot of debate on this at that era, and then they understood what could be the reason for this. Then there's something called Lloyd Laboratory. In the Lloyd Laboratory, Mrs. Corswell and along with the team of like Kevin J. Dorsey, they found out that the reason for the tumor necrosis is because of the tumor necrosis factor, which they could able to identify. So not only this, there's a supportive method like macrophages, which is actually having working towards that and reducing or killing or reducing the size of the cancer. So that has been occurred. That has been identified and make the development of our knowledge today. So if you see that a lot of tumor necrosis factors and different trials of interleukins, all these things is identified and over a period of time. When it comes to 1980s, so if you see Robert Moore and the team, they actually identified, understood that there is a lipopolysaccharide which is actually unresponsive, and responsive depends on the genotype or genetic mutation, because when they change the bone marrow from the previous bone marrow exchange to it, and with that mice, they actually only those mice used to get host response, whereas other mice is not getting the host response. So this model of adaptive transfer was used to evaluate the contribution of lymphoreticular cells to 5 effects of endotoxin on the host. So the host response is again, that's the reason why we call it a dysregulated response to different people to different way. So this is why we could able to understand that the depends on the endotoxin is released not by everybody. So this we can say that these results demonstrate that lymphocytes and or macrophages play a primary role in mediating a number of diverse and seemingly unrelated host response to. So the host response is more important than the toxin or the bacteria or the sepsis or infection. So this is a continuous process, which is really confusing. So conundrum, the host response depends on the multiple mediators like interleukins, tumor necrosis factors, and all these things. At the same time, it also depends on the person's phenotype and genotype. And the reaction is not simple, not straightforward. It is a very complex interaction, and it actually have different, like, up regulation and down regulation, which somebody is having a better, which somebody doesn't have a better recovery. So that is why one size does not fit all is sentence which fills into the most of the sepsis treatment we all know. So that is the reason that for all these decades, whatever interventions we are doing, it is not successful till date. That's why the change of definition is continuously happening, but the change of treatment is not happening. Not much of a difference, not much of usefulness we are able to really get from the mortality of that era to till this era, because the importance and the death rate of still very high in sepsis even today. So that's the reason we are able to still not able to go into the exact condition, and depends on the individual unless it's come to the precision making. So later, if you see 1976, so the first one was when we understood that it was around 1676. It took almost 300 years for us to compare to the previously. It is very fast understanding, fast knowledge, fast improvement, where he would able to say and studied looking at the prospective and retrospective studies, where he would able to make the improvement of almost, this is 42 to 14% and 39 to 11% of benefit of the patients by giving a steroid. So again, here he could able to identify what methylprednisolone is useful and which patients can be treated. And you can, any study we can say inclusion criteria, exclusion criteria. In that they could be able to understand and see that what is beneficial. So this was another which is even today, if you see analyst of surgery who has been actually is a surgeon, and even today we are debating on the steroids of the duration and the time and the dose. So that was a first study in 1976 which came up and given a boost for us. At the same time, if you see later, late Roger Bone, who was actually a controlled trial of high dose methylprednisolone has done for, where he has studied in a different method, different people, almost in 2 to 3 trials which they have given. Almost hundreds of trials have come into that practice. So when it came somewhere around in 1980s. So at that time, they actually understood, we conclude that the use of high dose corticosteroids provide no benefit in the treatment of severe sepsis and septic shock. This is where they have actually defined the difference between the severe sepsis, septic shock, and what actually clinical signs and symptoms. That is where we came into the picture, which is actually a pragmatic approach, and they actually made what actually sepsis syndrome depends on what signs and symptoms are there. There was no disease. So the flaw of this is that there's no commonality. It is a heterogeneous group. It is not uniformity. And you can always see that rubber collar, and this is called organ dysfunction, and altered mentation is nothing but capillary leak, or altered mentation is what you call pain. So then you have a elevated lactate and oligonucleotide. That means organ dysfunction. That's like, as you said, functional ASA. So these are things which you're able to understand, and they would be able to come up with some signs and symptoms how to identify. But it can be there for many cases, not only just for infection or sepsis. It can be there for trauma. It can be there for burns. So that is why it could not come to the biochemical mediators were different for many, and the respect to the site and the bacteriology of infection depends, varies from whether fungus, bacterial, viral, and the nature of the response evoked in the host is more important than the infection is being understood. But these are all the flaws of this study, and where we could not have a uniformity of this response or treatment. Now comes the starting of a defining era. The societies of, because that was all individuals and the people, now came to the societies. The Society of Critical Care Medicine, American Chest College of Physicians, both the societies actually came in 1990s, and in 1991 they actually come up with the saying that this is sepsis is it's almost a mixture of all this infection, sepsis, and celsius. So they came up saying that what is it can be because of bacteria, viral, fungal, others. So infection, sepsis, and cysts. Infection was defined as the presence of microorganism in normal sterile tissues. The resulting host systemic response was called the cysts. So that means it's not the real infection, it is a response of the individual what actually making the sepsis. So this is how they could able to diagnose, define, give the definition. The resulting host systemic response was called cysts. The sepsis was said to be present when infection resulted in cysts, recognizing that cysts can also be a consequence of sterile inflammatory process such as seen in the multiple trauma and burns or pancreatitis. So this is what the definition has come, and consensus of both ACCP and SCCM as given in 1992. So if you see that here, again, it is actually not the infection, it's the host response, which is again adaptive or appropriate. And can sepsis be beneficial then? So it's not sure, because some individual respond differently. As you said, upregulation, downregulation, and came to know what is infection, what is severe sepsis and septic shock. We all know the definitions now, but this was in 1991. So, but again, the cyst was undefined. What exactly is a definition of clear was cyst was not there. And at that time, there was a multi-organ failure that is being changed to the multi-organ dysfunction syndrome. So this has come into the syndrome and highlighted the continuum in severity and potential reversibility. So depends how you are going to take, how it's going to be important. This was sepsis 1 definition. So the cyst is nothing but, and it is non-specific, and particularly there was a bias because it has come from North America. European people never used to believe totally, and there's an inherent heterogeneity not resolved totally, and there is a biological therapy failed, because finally the outcome should be there. So when the cyst has been defined with a lot of things, but is not taken into the work so seriously, so beneficially, so that at the end of the day, it is okay, acceptable to certain level. Then in 2001, the Sepsis 2 consensus conference came by all these people like American Thoracic Society and American College of Chest Physicians, yes, European Society of Intensive Care and Society of Critical Care Medicine. So all these people, they expanded the CIS criteria. And also this is what suspected or documented infection, some of the following. Suspected or documented. So this is how it is, the general parameters, inflammatory parameters, because it's a host response, the hemodynamic parameters and organ dysfunction parameters and tissue parameters. All these parameters came into the picture, and they came to the consensus of the conference was in Sepsis 2 was they actually expand the CIS criteria, keeping the same mods and stratification system based on the Pyro model. So this is how actually they worked on. And what is important is the Pyro model is nothing but predisposition, insult infection, response, and organ dysfunctions. So this is what predisposition, insult, response, organ dysfunction model, which they actually said the present, future, and rational. So this is what they came up and saying that how important of the sepsis host response to be taken care. And in spite of having all these things, the outcomes, the activity, what we are doing is to control the host response, but not able to understand with exactly what person, which individual could go into host response could not be able to identify. So what they're only trying to treat the patients in a way of how to reduce the host response by looking at the nature of host response, degree of organ dysfunction, magnitude of the host response, and organ dysfunction. Sorry, resource allocation. So it depends on, it's not depends on the nature of infection. It is depends on the host response, depends on the including the comorbidities and the site of infection. These are all the things which actually came into the predicts the therapies to response to therapies has been taken. So, and now comes to the sepsis 3, which is actually in 2016. But again, it is not only American, both SCCM and ESICM, both the critical care societies have come, and this is, they came saying that it is life-threatening organ dysfunction caused by a dysregulated host response to infection. So it's a new definition. Please understand, this is a new definition as of now. So still further can be, it's a like conundrum going to have some more, because you need to have further as our knowledge and our understanding of the physiology and the which host is going to respond badly or which going to have a dysregulated host response, that will give us more change of new definition may come. So first we understood the infection. So these are the 3 main components. The second thing is a dysregulated host response, and the third is organ dysfunction. In that, again, most of things previously all were like expert opinion, clinical data. Now more of clinical data with evidence based. They said what exactly infection. So actually, there was a Q sofa which has come into the vogue, and everybody tried to use it, and now understood that it is not going to be much useful. It's not uniformity. And again, in dysregulated response, it depends on the hyperinflammation or immune suppression and complex. It's very complex. And organ dysfunction, clinical phenotype, focus on a consequence rather than the concept. No severe sepsis has come here. So that's why they said severe sepsis is removed, and sepsis and septic shock has come at this point of time. So, what is septic shock? A subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. So, please understand it's not just only circulatory, particularly cellular metabolic abnormalities are very, very crucial, important. In spite of having that, that is going to cause a metabolic circulatory insufficiency, which is a fundamental change in cellular metabolism, which is given a definition for the septic shock. So again, here you please understand the limitations. Not useful for early identification of infection. We may miss it, and does not resolve heterogeneity. And there's a lot of process issues here. And if you see in this definition in 2016 itself, they come up saying that there is one or two flaws, like, because the involvement of women were not there in the team. So there may be thought process would have been missed. And it is mainly did in high income countries, not in the low or middle income countries. Representation is not there. That's why again, still it can go into the accept of definition of the sepsis may change again. So what is organ dysfunction? The scores don't include endocrine because you are missing here. You are always having all the things like 5 vital organs, including the hematological, but missing the link of musculoskeletal and immune system and endocrine system. So this is why which the scores have not included in the organ dysfunction. That may be another thing. And if every one of us knows microbiome is important, as we are not just human beings, we are a mixture of microbiomes. So maybe we have to have that individual response may come from what way and which person normal host flora. So there's a limited variables to measure each organ system because we cannot measure every organ system fully. And there's again the baseline value has been lacking. What exactly and comorbidities are we already mentioned previously. So interaction between organ dysfunction and organ support remains unaccounted for. So that's still there's a lot of vacant space, vacuum, where we still have to understand much more to improvise and get into the correct and best definition of the sepsis. So again, we have to think of either it's a viral sepsis or non-infectious cause of sepsis, genetic predisposition, multimodal treatment, and iatrogenic damage. So the conclusion of the definition of sepsis is, as of now, this is the sepsis definition: life-threatening organ dysfunction caused by a dysregulated host response to infection. And new definition yet to come with few more understandings. And the conclusion is sepsis is immediately recognizable, unusually challenging to define. It's common but also grounded in a remarkably complex and effective homeostatic process. The obsession with the definition is both trivial and profound. So, what is trivial? It has not advanced the development of new therapies or facilitated fundamental new insights into biology because we are able to stop the response. We are not able to control. We are able to try to control the response, post response. We are not able to stop the response. And again, it's a profound is shapes how a common human illness is conceptualized and how it global impact on the human species is measured. So, still the death rate has been, even though we are able to prolong and improve to the maximum level with all these things, still we are not able to have the highest cause of death is after MI and cancer. Still the sepsis is the highest cause of death. We are still not able to really come to the control. So we still hope to see that end or keep changing our definitions with more and more knowledge and understanding and coming from the evidence-based clinical practices and research studies. Thank you.
Thank you, sir, for a very nice presentation of definition, how it evolved from over a centuries. So every time it is a new change and improve the outcome by changing the new concepts and treatment protocols. Any questions? Your time is around 30 minutes, sir. You said 15 minutes is your time in Eurasia.
Yes,
I
sir.
think
Any
in the beginning,
sir, okay. చెప్పండి sir.
the beginning slides means historical issues. I think you are taking more time for that. That is should be concised. You have more, you took more time for that and less time from rest of the slides. So I think you can reduce the period for that history for less time and more time for these definitions.
Thank you, sir.
Good morning,
Any
sir,
question?
and thank you, sir. Excellent presentation. And actually, your slides are also more colorful, sir. I liked that. Even though I am driving, I liked your slide.
Varalakshmi slides.
So, okay, sir. My question to you is: see, we have the SIRS criteria that is gone, and one now the definition of sepsis is there. One is dysregulated response, that is some organ failure, and second is a septic shock. So, what do you think, sir? Any issues in these definitions, or how we need to go for a better sepsis definition from your
See,
experience, or
yeah. No, I don't know. I cannot say much of my experience, but I can really say that because of this evolution, what you see, as per the improvement of technology, as per improvement of identification of the knowledge, the definition is getting changed. So that is the reason what we are going to understand is till the interleukins and host response knowledge has not come, we were supposed to think different definition. Once it came, it just came from external to the exogenous to the endogenous. So like that, as our knowledge response, whether it's going to be genotype or phenotype, and depends on the which gene is going to responsible. If we can able to identify much more into that, and as we come to know more and more about, we call it as a microbiome. You understand more of microbiome, then we may have coming towards our definition of sepsis may change.
sir, if a patient now sepsis is a dysregulated response, as you mentioned, see, a patient who is coming to us will have an organ failure, or then only now we can consider as a sepsis, because a patient who is having just fever, we cannot tell him as sepsis with a high grade fever, chills, and rigors. So now the dysregulated response, how much is the dysregulated response? And some patients we give a creatine. So one patient has come with cause of sepsis and creatine is 3. The next day patient responded, after 2 days responded well with a normal creatinine. Other patient did not respond even in spite of acute kidney injury. This type of some any, as you mentioned, with the inflammatory markers or some sort of organ failure things, should we categorize it as a sepsis, or what should we do, sir?
See, that is where the dysregulated coming now, sir, because dysregulated comes from individual person, individual response. The same infection, like, COVID, same score, same thing, or whatever, viral or bacteria, it is the response, host response is more important, depends on his. As I sent one paper has been put into the mice, because when they change that bone marrow, when they change that the phenotype of that, by changing the bone marrow, including of the gene, so the response was more. So like that, that is what is example I can tell you what I've been presented in the paper. The same way the host response depends on the person's response, not because of your treatment, not because of the infection, the same infection.
Sir, it is
Sir,
multiple factors are there, but can we measure a markers like, because you are going to the Eurasia, so a lot of top guns will be there. So you can you can discuss with them. Like suppose a patient, can we quantify a pro-inflammatory and anti-inflammatory markers, and one marker, not a multiple set of
Sir,
markers.
Ade sir, Srinivas garu, Jakina, the
Sir.
markers, sir, that is a response of that individual. Somebody is giving more markers, somebody is giving less markers. Depends on his response.
Yes, sir.
So that is again we have to come. Previously we has come with CRP, then we came with the procalcitonin, understanding seriousness. We are coming like that. We need to understand what is going to be the better response for the sepsis.
Yes. Yes, sir.
Sir, yeah, as you said, dysregulated host, the host defense mechanism will decide the response, how much respond, as you said, it is over responsive, hyper responsive, or hypo or normo, and there is a homeostasis of the immune system and the inflammatory system. But how the patient only will decide how much organ will damage, how many organs will damage, and how he is going into next stage of improvement or shock or multi-organ failure or death. Individual host response itself will decide. But are there any markers to decide which host is going to respond in a severity of the sepsis or septic shock or death? Are there any markers or genetic factors to identify which host is worsening, which host is improving? Any markers are there like that?
అంటే అదే సార్, ఇప్పుడు మనం మార్కర్స్ ద్వారా కేటగరైజ్ చేసుకుంటే సెప్సిస్ ఇస్ బ్రాడ్ టర్మినాలజీ.
Are there any?
లేవు సార్, ప్రెసెంట్లీ అయితే లేవు. బ్రాడ్ గా మనం మార్కర్స్ చూసుకోవడమే కానీ, బట్ దేర్ ఆర్ నో స్పెసిఫిక్ మార్కర్స్. సో మనం మార్కర్స్ ద్వారా కూడా మనం యాజ్ ఎ టెక్నాలజీ ఈస్ ఇంప్రూవింగ్, మార్కర్స్ ద్వారా కేటగరైజ్ చేసినాం అనుకోండి. సో నౌ వాట్ ఈస్ ద టైప్ ఆఫ్ ట్రీట్మెంట్ టు డిక్రీజ్ ద ఇన్ఫ్లమేషన్, లైక్ ఇన్ఫ్లమేషన్ తగ్గియాలా, యాంటీ ఇన్ఫ్లమేటరీ ప్రాసెస్ ఎక్కువ ఉందా? సో వీ నీడ్ టు లుక్ ఇన్ టు దట్ ఆస్పెక్ట్స్. అది.
But anti-inflammatory medication also will not change the patient prognosis, kada. Otherwise, everybody can be given steroids and can reduce the inflammation, and you can.
యూరోఏషియాలో నేను ఏం క్వశ్చన్ అడగాలి చెప్పిన అయితే మొత్తానికి మార్కర్ ఏంటో తెలుసుకోవడానికి అడగాల.
అంటే అది కాదు సార్, క్యాన్ వీ హ్యావ్ ఏ కేటగరైజేషన్ ఆఫ్ ద సెప్సిస్? సెప్సిస్ ఈజ్ అ బ్రాడ్ టర్మినాలజీ. సో ఇట్స్ అ ఎండ్ ఆర్గన్ డ్యామేజ్, అంతే కదా సార్? ఇప్పుడు సెప్సిస్ అంటే
ఎండ్ ఆర్గన్ డ్యామేజ్ మే హ్యాపెన్, మే నాట్ హ్యాపెన్. వరలక్ష్మి ఉందా ఇందులో? జాయిన్ అవ్వలేదా?
అంటే సార్ డెఫినేషన్ లోనే వాట్ దే గివెన్ డెఫినేషన్, ఇట్ ఈస్ ఏ లైఫ్ థ్రెటనింగ్ ఆర్గాన్ డిస్ఫంక్షన్ డ్యూ టు dysregulated host response. So there is a definitely organ dysfunction to diagnose the sepsis.
అదే ఇప్పుడు పేషెంట్ ఫీవర్ విత్ బ్రెత్లెస్నెస్ వచ్చింది అనుకోండి సార్, అండ్
there is a one organ.
వన్ ఆర్గాన్. సో సార్ డిస్రెగ్యులేషన్ ఎంత ఉన్నది అనేది మనకి ఏమైనా క్వాంటిఫికేషన్ తెలుస్తుందా?
లేదన్న, ఐ డోంట్ థింక్ దేర్ ఇస్ ఎనీ టెస్ట్.
సార్ ఇది ఇప్పుడు మనకు తెలియదు కానీ ఇన్వెస్టిగేటర్స్ ఉంటారు కదా, వాళ్ళకి ఇది స్టిమ్యులేట్ చేసి చెప్పడమే.
Might be in the process, research process. We have to అవి కూడా తెలుసుకోవాలి. We should know
so that we will get a better this one definition.
Sir, another question. What is the role of QSOFA?
The role of QSOFA was there before, as you said, heterogeneity. It has not come in many benefits. It's only been useful in the early recognition of the signs. The same signs and symptoms can be there for without infection also. You cannot make only infection or serious sepsis. You can able to early identify, early recognition of the people where you can prevent the further damage. But it's not confirmed that it's only sepsis. It's not useful in ICU. It's useful in the wards where, like, early warning, muse is there, no? Early warning signs. Like that we can able to identify, which cannot be given for, it's not for compulsory sepsis. It's not proven because all are not included in that.
So when inflammatory when inflammation is there in non-sepsis like trauma or autoimmune
we said
diseases.
no, burnt trauma and pancreatitis.
How do you differentiate exactly sepsis or non-sepsis? Early, not after 2 days after culture. How early?
Sir, as per the definition, what will is same thing, sir. 6 criteria. That is what is in only they reduced to the only 3-4 things in QSOFA, like organ involvement, like mentation, and pain is there, or fever is there, which has not shown, only just looking at the respiratory rate and blood pressure and mentation. So they have not taken into all things into the consideration. That's why it is definitely good for early.
Hello? హలో
సార్ డ్రైవింగ్ లో ఉన్నట్లున్నా సార్ కానీ డిస్కనెక్ట్ అయింది
సార్ డాక్టర్
మీరు
సతీష్
comment చేయండి, sir.
wants to ask one.
సతీష్ జక్కిన రాణి మేడం, ఎవర్ ఇట్ ఇస్.
సతీష్
మీరు
చేయెత్తాడు
చెప్పండి. మౌనంగా ఉన్నాడు లైన్ లో.
సతీష్ చేయెత్తాడు. సతీష్ ఆస్క్.
Sir,
మౌనంగా
morning.
ఉన్నాడు. చెప్పండి
Hello?
సతీష్ సార్.
సతీష్.
Sir, whatever it is, the present situation, like we understood the definition of the sepsis, what you said is host response, dysregulation of the host response to some insult. But at the same time, how many of we are ignoring the SIRS criteria as of now? Are we following
We are
SIRS
not
criteria or
ignoring.
not?
Even though we are not following strictly, but we are following it clinically.
100% we are following, sir.
One more thing, sir. The QSOFA came in 2016 and everybody was behind that and they applauded those people that I think I forgot his name. And everybody was very, very like it is a new intervention, new invention happened. But thing is, he included only 3 parameters like heart rate, BP, and organ dysfunction, altered mentation, which is a part of the SITS criteria, and it was given a lot of hype in those days. The definition changed and SITS is not included. Now it is only 2 parameters. So all those things were there, and because they are Westerners and they could make it in a very rosy presentation, people were behind them. But of late, within 2 to 5 years, it got disconnected. So we are not very happy with the definition what they have given, and it was kept aside. So so as of now, in this era also, subconsciously, we are all following the SITS criteria. We are all following the, like, what are the 5 parameters you are given, no? Inflammatory criteria, organ dysfunction criteria, hemodynamic criteria. So all these things are subconsciously we are following, and we are categorizing the patient as per the available data of that patient. Subconsciously, we are all tuned to that. But thing is, no, what Srinivas sir is telling that when the definition is telling about there are 4 components in that new definition. Dysfunction, organ dysfunction, dysregulation. So dysfunction should be categorized. So it's like stage 1 dysfunction, stage 2 dysfunction, stage
Sir,
3.
only 3 no, sir. Infection, dysfunction, and dysregulation. I mean,
Sir. So that one. So the thing is, we have to have a criteria for evaluation or staging the dysfunction. Also, we need to identify some marker and the severity of that marker rise or severity of that marker decline. So these 3 parameters should be elaborated as per the definition.
నా సోఫా స్కోర్ అదే కదా, సోఫా అండ్
But it,
అపాచీ
yeah, but
on the severity we can categorize the
see, that's what we are doing Apache 4 for every patient in ICU. But Apache 4 is completely patented. We don't have control of each parameter. We have to plug in the values so that you will get an automated calculated Apache scoring, and that gives a mortality.
course చేస్తున్నారా ప్రతి పేషెంట్ కి?
Yes, sir. We are doing. For the last 6 months, I am doing.
I think Mohan Rao told me that there is a calculator including both Apache and SOFA score.
That's what I'm telling. So, in this Apache score 4, you just plug in the parameter. That's all. You don't have any control. See, previously when the Apache score, there is a range. You know that low BP or very high BP, low TLC, very high TLC, we can predict the score. But in this Apache 4, The predictions are very, very variable. So this is a different aspect. I will talk on that in the next class. Maybe I'll give me a chance so that we can organize some talk on the Apache 4. But thing is, Apache 4, we don't have a control. It is a patented format. We don't have any specific rationale behind that, why it is showing like that. So these scores are not.
Apache for next talk.
Yes, sir. Yeah. Yes, sir. So my idea is we need to have the each point criteria in the definition and should be elaborated. That as Srinivas sir told, you may ask these things to the experts there.
Rani madam trying to ask something, madam. Hello? Madam.
Hello, Andy.
Madam,
అడగలేదు సార్ బట్ జస్ట్ వండరింగ్ ఇన్ డెఫినేషన్ ఆఫ్ సెప్సిస్ స్కోరింగ్ సిస్టమ్ వస్తుందా అనేది చిన్న డౌట్ వచ్చింది అంతే.
I think you need to mention scoring systems also at the end. And sir?
Definition of scoring system రాదు.
Scoring system రాదా?
Scoring system
Definition రాదులే?
Yeah, that's what I was thinking, but if sir wants, he can mention like scoring system ante malli Apache or Sofa lo like simple physiological variations nundi like going up on the score may indicate severity of sepsis and cheppochu kani, but in the definition it's not there.
Definition lo undadale. Sir, what is the importance of procalcitonin and CRP to differentiate sepsis and non-sepsis? Hello?
Sir, ante మీరు like in future definitions maybe they'll include markers or scoring system to classify severity of sepsis అనేది మెన్షన్ చేయాలంటే చేయొచ్చేమో in future, but it's not done. Every few years review చేస్తుంటారు కదా, ఏదో ఎవరి బుర్రకు తోస్తే వెస్ట్ లో వాళ్ళు అలా పెట్టేస్తారు.
Role of procalcitonin and CRP to rule out sepsis, sir. Hello?
Rule out sepsis.
Rule out అనలేం కదా డేవిడ్, because the specificity sensitivity లేదు కదా.
Yeah, you cannot rule out
కాదు కదా.
What is the importance of procalcitonin and CRP?
Negative predictor కదా sir, along with the clinical parameters. It basically rule outs and rule in కదా.
ఏది PCT? No.
It has a strong negative predictive value along with clinical.
You cannot diagnose
say it's an infection.
With...
Yeah, severity you cannot say if it is
not
100.
Only severity, procalcitonin even though high, it is not definition of diagnosis of sepsis.
Yes sir, అదే సార్. అంటే ఇప్పుడు మనము we can rule out the infection with the procalcitonin is negative and clinically patient is not having a signs of SERS criteria. Clinical వాడు ఏమంటాడు డెఫినేషన్ లో, procalcitonin negative along with that clinical criteria you can rule out a sepsis అని అంటాడు. కానీ sepsis రూల్ ఇన్ మాత్రం చెప్పలేదు
సార్. ప్రోకాల్ రూల్ అవుట్ కూడా చేయలేమేమో సార్. Procal normal cannot rule out the infection. It can be fungal, it can be viral. So
నేను అనేది అదే. ఇప్పుడు ఫంగల్ ఇట్ కెన్ బి పాజిటివ్, ఫంగల్ అండ్ బ్యాక్టీరియల్.
You can't అంటే కొన్నిసార్లు
వైరల్
నెగటివ్ అంటే చెప్పలేం. We can't rule out infection.
అంటే along with the clinical అన్నాను కదా, we cannot see only procalcitonin. So
is asking about only procal and CRP.
దానికి రోల్ లేదు కదా, సెప్సిస్ డెఫినేషన్ లోనే ఇచ్చాడు కదా వాడు, సెప్సిస్ గైడ్ లైన్ లోనే ఇచ్చాడు. యూ హ్యావ్ టు ఆల్వేస్ along with the clinical things only you have to evaluate. Viral definitely procalcitonin will not help. We have seen COVID lo any లీస్ట్ ఎప్పుడన్నా చూసామా అసలు క్లినికల్ సిమ్టమ్స్ అంత సిక్ ఉండి ప్రోకాల్సిటోన్ 0.001 0.002?
ఇంకా సజెషన్ చెప్పండి బాబు మాకు.
సార్ మోహన్ సార్,
చెప్పండి సార్.
nice class. I have one doubt, sir. So with current definition, what evaluated with this, how much percentage of sepsis cases or septic shock patients we can diagnose, sir, or we can miss now? How much percentage we can miss with this definition?
ఈ డెఫినేషన్ లో మిస్సింగ్ అంటారా? తెలుసు నాకు కనుక్కోవాలి.
Yesterday I had one webinar. The hostel people have given means statement that with current definition also, with the definition also, we are unable to unable to diagnose the sepsis septic shock or happening delay. So we are losing the patients. Certainly needs maybe evaluation of the definition. Maybe we are sepsis and septic shock patients will present in a varied of symptoms, varied of presentation to the issue. Is there any data, sir?
నిన్న మీరు చెప్పిన టాపిక్ నాకు కూడా పెట్టండి ఒకసారి, నేను కూడా వింటాను. ఎందుకంటే అది ఇంపార్టెంట్ కదా.
Sir, as you mentioned, it's correct, sir. We can miss the patients because the sepsis. See, we need to have an organ dysfunction for the sepsis definition. Okay. So without that organ dysfunction, sepsis undanukondi, then we cannot identify it as a sepsis. We cannot take into account.
What you are not taking into account?
Sir, ఇది dysregulation with organ dysfunction కదా సార్. మీకు ఏదో ఒకటి ఆర్గన్ డిస్ఫంక్షన్ ఉండాలి, లేకపోతే యూ కెనాట్ క్వాంటిఫై ఇట్ యాజ్ ఎ సెప్సిస్.
దానికి అందులో టాక్ లో స్లైడ్స్ లో ఒకటి చెప్పాను, గమనించండి. ఇఫ్ సీ ద స్లైడ్స్ ఒకసారి మళ్ళీ నేను చూపిస్తాను కావాలంటే. అందులో ఆర్గాన్ ఎవాల్యుయేషన్ ఫర్ ఆల్ ఆర్గాన్స్ లో 3 మిస్ అయ్యాము. ఒకటి మస్క్యులోస్కెలిటల్ సిస్టము, ఎండోక్రైన్ సిస్టము, ఇమ్యూన్ సిస్టము. ఈ 3 మిస్ అయ్యాము, ఇందులో లేదు. So that is the reason why we are not able to really go through. And differently, every organ, if you see, one kidney, if the creatinine is bad, urine output is both bad, it is compulsory that it has been damaged. But if the urine output is good, creatinine is okay, but still can be manageable. That's the reason we are not inclusiveness of everything is not able to assess. That's the reason I have given you in the beginning of saying that the what you call all the domains of possibilities and process, like the inclusion criteria of process, reliability, and all these things. When I told in the definition, everything is not included in this definition. So that's the reason, as Mohan Rao said, we still can miss it.
Sir, how will you differentiate the patient already having organ dysfunction like chronic liver disease, CKD, and COPD?
That's what I'm telling. See, for just
sepsis.
like a cognitive, like post-arrest cognitive function, we have to have a baseline, because unless we have a baseline, that sentence also I've written in the slide. Unless we know the baseline, we know what is the problem. So baseline should be there to understand that it's worsening or not worsening.
Baseline, if you don't have baseline, they don't come with reports. No?
That is what I'm telling you. That's where the missing is.
ఇవ్వనా ఆదివారం వచ్చినాక ఇవ్వనా
వచ్చేస్తా
కదా సత్యబాబుకి మళ్ళీ సత్యబాబు
రాణి మేడం ఏంటి చెప్తున్నారు?
ఏం చెప్పట్లేదు, మీట్ చేశాను.
ఓకే, రైట్. సో ఆ స్లైడ్స్ లో చెప్పాను, బికాజ్ బేస్ లైన్ తెలియకపోతే మనం చేయలేము. వి డోంట్ నో, వి మిస్ ఇట్ సార్.
Sir, patient with pain abdomen.
Sometimes they don't have but you can identify like ultrasound contracted kidneys or cirrhosis. All these things can be identified by bedside ultrasound, no? Is it possible?
Sir, if you say any organ, it to reflect that it has been damaged, minimum 30% of the organ has to be damaged already. So whether it's a normal organ before, already 30% damaged organ, we don't know. That is the reason we should have in a baseline. We don't know whether it's a previously damaged and now it is damaged. any investigation abnormality will come only after 30% of the organ has been lost, functional loss or physiological loss.
Okay, sir. Any questions?
Sir, a patient came to me with pain abdomen, sir. So I thought right-sided iliac fossa pain. So సర్లేండి వాడి అక్యూట్ జీ కూడా ఉంది. సో 3-4 times లూజ్ మోషన్స్ పాస్ చేశాడు. సరే రారా బాబు అని ఏదో మామూలుగా క్లినిక్ లో ఏదో మెడిసిన్స్ రాసి పంపించాము. నెక్స్ట్ డే వచ్చాడు మళ్ళీ పెయిన్ అబ్డమిన్. సరేనా అల్ట్రాసౌండ్ చేయించాను. First day I did not start on any antibiotics because I thought it's viral. Second day he came again. So he had ultrasound is showing appendicular abscess. Mild fever undi, ఇది ఉంది. But he also again at that time he says that నాకు అప్పుడప్పుడు వస్తుంటది నొప్పి అని చెప్పాడు హిస్టరీ. ముందు కూడా చెప్పాడు బట్ అల్ట్రాసౌండ్ చేయించలే. సో ఇప్పుడు అది సెప్సిస్ అంటారా సెప్సిస్ కాదంటారా సార్? అది ఇప్పుడు వీడికేమో యాంటీబయాటిక్ ఎర్లీగా స్టార్ట్ చేయాలి బికాజ్ అపెండిక్యులర్ యాబ్సిస్. సెకండ్ డే స్టార్ట్ చేసాము. బట్ ఇస్ ఇట్ ఏ సెప్సిస్ ఆర్ నాట్ సెప్సిస్? మోహన్ రావు గారు చెప్పండి సార్.
It is septic, not septic shock అనుకుంటాను. మోహన్ రావు
సార్ మీరు విన్నారుగా ఇట్లాంటి ఎగ్జాంపుల్స్ ఏమైనా విన్నారా? సార్ మోహన్ సార్.
No, I don't know.
Sir.
Somebody is talking. Your Varalakshmi.
Sir, good morning, sir. Sorry, I joined late. సార్ మనం ఈ క్లాస్ పర్స్పెక్టివ్ తో ఆలోచిస్తే ఇప్పుడు సెప్సిస్ 1 డెఫినేషన్ పెట్టామనుకోండి సార్, మీరు చెప్పిన కేసుకి శ్రీనివాస్ సార్.
చెప్పండి.
సో వీ హ్యావ్ టు లుక్ ఎట్ వెదర్ దెర్ ఇస్ ఇన్ఫెక్షన్ విచ్ ఇస్ ఇట్ సీమ్స్ లైక్లీ. వీ డోంట్ నో వాట్ ఇన్ఫెక్షన్ ఇట్ ఇస్ బట్ సమ్ ఇన్ఫెక్షన్ సీమ్స్ లైక్లీ. తర్వాత మనకి సర్చ్ క్రైటీరియా ఉన్నాయా లేదా? సర్చ్ క్రైటీరియా ఉంటే సెప్సిస్ ఉన్నట్టు, లేదంటే సెప్సిస్ లేదు.
లేదు మేడం, నేను
see that is how we have to go by. So does that patient have fever? Does that patient have
I'm not asking ఇది మేడం, దట్ ఇస్ క్లినికల్ క్రైటీరియా మనం ఎట్లా చూసుకుంటాము. సో what I'm thinking is only I'm trying to look into how can we improve this definition.
exactly.
Dr. Mohan Rao has mentioned that the patients we are missing a diagnosis if we go strictly through the criteria.
Exactly, sir.
So this is one of the classic case I felt. I thought ఎందుకంటే నాకు జస్ట్ సడన్ ఇప్పుడే గుర్తుకొచ్చింది. So I see various types of this type of cases and good diagnosis later on evaluation. But the patient first days I did not start on antibiotics because సర్లే చాలా మంది వస్తున్నారులే అనుకున్నాను. Different case. So we cannot identify in first instance, but at the same time as Mohan Rao mentioned that this type of cases they might be missing and they are losing the patients.
Exactly, sir. That's the reason there is a topic called evolution of definitions in sepsis, because it is nowhere even close to perfect.
So వీడికి ఏంటంటే he presented with fever.
What is the Mohan Rao question అడిగినప్పుడు విన్నావా వరలక్ష్మి?
విన్నాను సార్. What is the sensitivity and specificity అడిగారు.
Specificity of the definition.
It is very very difficult to establish. Americans, Europeans వాళ్ళు ఇన్వాల్వ్డ్ కాబట్టి వాళ్ళు బాగుంది అంటారు. ఆస్ట్రేలియన్స్ ఎమర్జెన్సీ ఫిజిషియన్స్ వాళ్ళు ఇన్వాల్వ్డ్ కాదు, వాళ్ళకి నచ్చలేదు కాబట్టి సెన్సిటివిటీ బాగలేదంటారు. ఇట్స్ వెరీ డిఫికల్ట్ టు ఫైండ్ ఎగ్జాక్ట్ లిటరేచర్.
ఇండియన్స్ ఏమనుకుంటున్నారు?
ఇండియన్స్ డబ్బులు ఎక్కడ వస్తే అది ఓకే అంటారు.
మీరు అట్లా కాదు మేడం. We read both of the articles and we decide our own things.
ఎగ్జాక్ట్లీ సార్. సో వీ హ్యావ్ టు పే కేస్ బేసిస్ మనం ముందు నుంచి చేసేది అదే కదండి సార్. జస్ట్ బికాస్ ఇట్ డజంట్ ఫుల్ఫిల్ క్రైటీరియా మెనీ టైమ్స్ వీ డోంట్ స్టాప్. విల్ స్టార్ట్ వన్ యాంటీబయాటిక్ సరే పెట్టి చూద్దాం అంటాం కదండి సార్. ఐ మీన్ దట్ ఈస్ వేర్ బికాస్
ఎందుకంటే వై ఐఎమ్ బ్రింగింగ్ దిస్ థింగ్స్ ఈస్ వీ నీడ్ టు, ఇప్పుడు సంగారెడ్డిలో ఉన్నారు పేషెంట్, సంగారెడ్డిలో ఉన్న పేషెంట్ కూడా అక్కడ డాక్టర్ కూడా ఏబుల్ టు ఐడెంటిఫై ఇట్, బికాస్ వెన్ వి డిస్కస్ దీస్ థింగ్స్ విత్ బికాస్ ఐ గెట్ సమ్ రెఫరల్ పేషెంట్స్ అది, సో దే ఆస్క్ మీ సార్ ఇది లేదు కదా ఇప్పుడు క్రైటీరియా, సెప్సిస్ ఉన్నది కదా, ఇది ఉంది కదా అని. సో ఐ ట్రై టు ఎక్స్ప్లెయిన్ దెమ్. సో యాజ్ సమ్ గైడ్ లైన్ కమ్, న్యూ గైడ్ లైన్ కమ్, దే గో టు ద కాన్ఫరెన్సెస్. మనమేం పోయి కూర్చోం కదా, ఇప్పుడు యూరో ఏషియాలో పోయి వినడానికి కూర్చోం కదా, స్పీకర్స్ విల్ గో ఎట్ అవర్ లెవెల్. సో దీస్ పీపుల్ విల్ గో ఫ్రమ్ ద ఫ్రమ్ నర్సింగ్ హోమ్ లెవెల్, వీళ్ళు పోయి విన్నప్పుడు ఏంటంటే దే విల్ యూజ్ ఓన్లీ దిస్ యాజ్ ఏ గోల్డెన్ థింగ్. So we need to look into and we need to explain them.
Exactly, sir. Agreed, sir. 100%.
Okay. Sir, in a definition of septic shock, you have mentioned it is a profound circulatory and cellular metabolic abnormality. Circulatory means hypotension. What is the meaning of cellular and metabolic abnormality? How do you define that? How do you quantify that? Hello? Hello?
Sir, చెప్పండి సార్.
What is metabolic? What is cellular? And how do you differentiate both? And how do you know that the severity of metabolic and cellular? What are the parameters?
Sir, ante mano ఈ డెఫినేషన్ లో the changes that have been brought imply that all the changes in or all the organ dysfunction is not entirely due to hypotension, sir. Dani meaning, I think that is the meaning. It's not only hypotension, it is so many other things, like there is a change in oxygen consumption, there is no cells go into energy, then there is limited utilization of metabolic products, there is increased catabolism. So and in nutrition wise, patients don't absorb, they don't use their nutrition properly. So at every organ level there are changes which are not explained only by hypotension, sir, which happen in sepsis. So that is what is highlighted in this sepsis 3.
డేవిడ్ ఆన్సర్ వచ్చిందా? మెటబాలిక్ సెల్యులర్ కి రాలేదా?
Sir, I didn't get that connection. Can you explain the cellular and metabolic abnormality? How do you diagnose and how do you differentiate, and how do you know the severity of these both cellular and metabolic? What are the parameters?
వరలక్ష్మి వినలేదంటే డేవిడ్ ఒకసారి.
నాది కట్ అయిపోయింది. సరే చెప్పారా
డేవిడ్ గారు? హలో అమ్మ వరలక్ష్మి, కట్ అయ్యారా ఉన్నారా?
Sir, cellular and metabolic abnormalities have to be with, we will correlate with business, lactate elevation and ammonia elevation and all, and development of anaerobic metabolism at the cellular level.
అంటే అది లాస్ట్ ఎండ్ ప్రోడక్ట్ కదా. సో వాట్ సార్ ఈజ్ ఆస్కింగ్ ఈజ్, డేవిడ్ సార్ ఏమంటున్నారంటే నాకు లాక్టేట్ పెరుగుతుంది అంటే ఐ నో దట్ ద పేషెంట్ ఈజ్ గోయింగ్ ఇన్ టు వర్స్ అవుతున్నాడు. లాక్టేట్ ఇంప్రూవ్ అవుతుంది అంటే ఇది. ఐ డోంట్ వాంట్ ఎట్ దట్ లెవెల్, ఐ వాంట్ ఎట్ ద ఎర్లీ లెవెల్. వాట్ ఈస్ ద సెల్యులార్?
అంటే నేను షాక్ లెవెల్ అని అడుగుతున్నాను. షాక్ డెఫినేషన్ అది కదా సెప్టిక్ షాక్.
గో అంటిల్ ద పేషెంట్ ఈజ్ వర్సన్.
Yes, sir. But the same answer, sir. Actually, Srinivas, sir. Actually, you suggested one clinical scenario. Patient come with abdominal pain and all. The difference between the Western world and Indians is we will not investigate so early, sir. Even for the simple sore throat also, actually they will keep a throat swab whether to confirm if it is viral or bacterial to initiate antibiotic and all. So we will not investigate so early. That is one of the
అవును
drawback
సార్,
when
మన
compared-
క్లినిక్ మళ్ళీ రాడు కదా సార్ అన్ని సెప్సిస్ రాస్తే.
Yes, sir. For them that is all free, but for us actually everything from pocket.
నేను ఒకటే రోజు 3,000 చేశాను అనుకో, వాడు రాడు.
Yes, sir. The main idea. Yes, sir. The main idea in sepsis is to differentiate inflammation from infection with inflammation. We should not overtreat inflammation. At the same time, we should not miss infection with inflammation. That is the idea. That's why we will be more aggressive in when there is a shock patients. When there is no shock and when the patient is clinically stable, the thing is we can wait for some time. The patient suppose comes for OP, we will not be more aggressive. But the patient coming to ER, we will be more aggressive in identifying.
అంటే in terms of even antibiotics also, the patient in sepsis,
yes sir,
not in septic shock, delay in antibiotic is not going to kill the patient.
Yes sir.
Okay,
but the thing is, suppose in pancreatitis and all, there is a severe inflammation with organ dysfunction. But the thing is, the idea is to, this definition is to eliminate all conditions where there is severe inflammation with organ dysfunction, but there is no infection. Is it not, sir? Always, if you see the modifications of definitions, everywhere we will trying to always eliminate all inflammatory conditions from the infectious condition. Is it not, sir?
Inflammation, అందుకనే what he has said, when a patient is in septic shock, delay in antibiotic is going to kill the patient.
Yes sir. That's why actually when the
patient is in sepsis.
Yes.
So as I mentioned an example already, the patient is in sepsis, that patient delay in antibiotic is not going to harm the patient. Okay, but adi enta delay anedi not there, but at least early antibiotic therapy is not going to kill the patient. Not giving early antibiotic is that time.
But at the cost of this over treatment will be there, sir. Means suppose if you don't rule out the inflammatory conditions, we have to over treat.
Patient with severe acute pancreatitis with a multi-organ failure,
for all organ dysfunction, we have to be more aggressive, sir. Even shock also, you have to be more aggressive.
A patient presented with you for a pain abdomen,
yes, sir.
diagnosed with appudu pain abdomen with renal failure. Okay, and then do you start antibiotic or not? Found to be acute pancreatitis. Start
yes, sir. The thing is, suppose we have to rule out, sir. Suppose if it is renal colic again.
No. I told very clear example, Andy.
Yes.
Patient with an acute pancreatitis.
Yes,
okay?
If
Having a renal failure. Now you consider this patient as a sepsis. Will you give an antibiotic or not?
Hello? Amma?
If it is clear-cut sepsis, there is no. If there is no clear-cut pancreatitis,
no, how will you
no
identify
hypotension.
How will you identify?
Yes, sir.
See, these are all the gray areas.
Yes, sir. Actually, all Sears marker will be elevated in pancreatitis. Even organ dysfunction also will be there. But again, we will not start antibiotics. We will wait, sir.
With the sepsis?
If it is shock only, then we will start. That also empirically. Otherwise, we will wait, sir. For a severe clinical history suggestive of more of pancreatitis with organ dysfunction, all Sears markers present, but still we will wait, sir.
మీ సార్ ఒప్పుకుంటారా పేషెంట్ విత్ పెయిన్ అబ్డామిన్ ఆర్గన్ ఫెయిల్యూర్ కమింగ్ టు
క్వశ్చన్ అడుగుతాను మోహన్ రావు
sir actually I have a doubt man. in the downtime, and I think you are the senior most intensivist in Vizag among us also. So, and it means, is there any can we expect any point of care test? Means coming days, coming 5 years or 10 days to diagnose sepsis or septic shock, sir? Can we expect? So which actually gives answers to the our this dilemmas, very varied presentation of sepsis. Can we expect, sir?
Maybe this markers ఉన్నాయి కదా, biomarkers. That is only the future where we can get like a PCR now. The early all interleukin markers, whatever we are able to, maybe over a period of time it will come. That's what I'm thinking. I don't know. Breakfast better, huh?
Sir, the gray area where the Ramanaidu told. Sir.
Yes, sir. Actually, as like sir
Yes, sir.
told, actually we will take the help of biomarkers.
What the
in those cases.
Ramanaidu said. Yeah, pancreatitis with mods, search, everything will be there. It mimics like sepsis, even with hypertension. But at the same time,
David అసలు ఏం వినపడలేదు. David వినపడలేదు.
Exactly, we don't. The patient having fever and also sepsis related parameters. But what I'm seeing, all the
Fourth. Counts pancytopenia ఉందా?
David వినపడలేదు David.
వచ్చిందంటే మరి ఇది రావాలి.
కరెక్టే కదా.
Sir, 9:15 అయితంది. With your permission, can I exit?
Yeah, please. Thank you.
Okay. Thank you, sir. Nice discussion, sir.
We will continue after the Apache score 4 by Satish.
Sir.
చెప్పండి.
సార్ డేవిడ్ సార్ ఫోన్ హ్యాంగ్ అయిపోయింది సడన్ గా. సార్ పక్కనే ఉన్నాడు సార్.
నీ ఫోన్ లో మాట్లాడేమైంది? నీ మాట ఏమి వినపడలేదు సరిగా ఇందాక.
Close the session. Time is over.
Thank you.
Thank you, sir, for a nice presentation. All the best for Euro Asia presentation. Thank you.
Thank you, sir.
Thank you, sir.
Thank you all.